disease, but at least suggested that some ET patients have a predisposition to develop PD and underlying dopaminergic deficiency. So that brings up the question of misdiagnosis of essential tremor and Parkinson's disease because of overlapping features and absence of diagnostic biomarkers. These two most common movement disorders are frequently misdiagnosed. So ET is the most frequent correct diagnosis in patients who were initially misdiagnosed as PD, as demonstrated by these two studies. But ET may actually follow PD, which is even more challenging diagnostic issue that I will discuss in a moment. So typically, ET precedes ED, so we call it antecedent ET in patients who have Parkinson's disease but have prior history of ET. But in some cases, the ET can follow PD, so be antecedent PD in patients who have ET. So how do we diagnose essential tremor in a patient who already has Parkinson's disease? So these are two studies that I just want to highlight that have shed some light on it. In the first study, we looked at 22 patients that had childhood or young onset essential tremor and were subsequently followed, and they developed Parkinson's disease later on. But interestingly, almost all of those patients that had asymmetric onset of essential tremor, the onset of their Parkinson was consistent with the side that had the more prominent essential tremor. And Alan Lewis had a similar studied 53 patients, and again concluded that the site of the greatest initial ET severity corresponded to the site of the greatest PD severity. So again, I want to emphasize the importance of obtaining history of tremor prior to the onset of Parkinson. Many patients who have onset of tremor, let's say in a right hand, they often attribute the onset of their condition to the onset of the right hand tremor. But it's not until you ask them whether they had tremor prior to that, they may finally volunteer the information that they may have had tremor for years or decades, even prior to the onset of the right hand tremor. It's often wrongly attributed to stress, alcohol, age. But there are other features that one should look for in a patient with Parkinson's disease to determine whether they also have coexistent essential tremor. For example, head tremor. It's almost unheard of for head tremor to be seen as Parkinson's disease and manifestation. In fact, if I ever see a patient with Parkinson's disease with head tremor, I strongly suspect that they have a coexistent essential tremor. Also, voice tremor is not common in Parkinson's disease, but obviously is very common in essential tremor. Writing and drawing tremor is a typical feature of essential tremor, but not Parkinson. Patients with Parkinson have micrographia, but they usually don't have writing or drawing tremor. There's no latency when the patients are asked to assume a horizontal position in outstretched arms. They have tremor immediately, whereas patients with Parkinson's disease have this classic reemergent tremor that we described many years ago. The tremor in patients with Parkinson's disease, if it responds to alcohol, propranolol, primidone, might suggest that there's a coexistent essential tremor. And certainly if there's a family history of tremor or alcoholism, that could also suggest the possibility of coexistent essential tremor. So I think everybody is familiar with the features of essential tremor that I don't have time to belabor. I do want to point out that there is a bimodal age at the onset of an essential tremor, and we demonstrated this in several studies. So many patients start with essential tremor even in childhood, and they usually start with action tremor, but often later develop rest tremor. They may have hand tremor as well as head, voice tremor. They may start with task-specific writing tremor, for example, that may evolve into a full-blown essential tremor. And we talked about tremulous handwriting. Many patients with essential tremor also have loss of hearing, gait ataxia, and there's evidence from Alan Lewis studies, autopsy studies, suggesting cerebral pathology in some patients with essential tremor who come to autopsy. And obviously, the patients with essential tremor respond to alcohol, beta blockers, and primidone. And obviously, I don't have time to discuss the clinical features of Parkinson's disease that are so familiar to all of you. Just want to emphasize the feature of reemergent tremor, where the patient is asked to outstretch the arms. There's often a latency of several seconds or even minutes before the tremor reemerges. That's usually tremor that is present at rest, but after a period of latency, it occurs and reemerges during this partial holding. So many patients then develop combination of ET-PD with rest and action tremor. They often have family history, mild dopaminergic deficit by imaging, and then this entity, benign tremulous Parkinsonism, may be an example of ET-PD combination. So more recently, the Movement Disorder Society published a consensus statement on classification of tremor, and they introduced this new classification called ET+, which consists of patients who have ET-like phenomena in terms of their partial tremor, but they have additional features of uncertain significance, such as impaired tandem gait, questionable dystonic posturing, memory impairment, or other mild signs of unknown significance. So it's this entity of ET+ is somewhat vaguely described, but suggests that some patients with essential tremor may have more than just isolated tremor, but may have some additional features. So ET is a syndrome, according to this consensus statement, that may evolve into another tremor syndrome, and these patients that have antecedent ET. So that, again, this introduced a whole new controversy as to what is the difference between ET and ET+. Many patients who used to have ET now are told that they have ET+. And in fact, in many clinics, if not most of the clinics who examine the prevalence of ET+ versus ET, found that ET+ actually is more common than isolated ET. This is also true in our experience. This is a paper was just published where we examined 300 patients with essential tremor and found that about 21% were classified as having isolated ET, but majority, 53.3%, had ET+, and 26% had the ET-PD combination. So we concluded that additional motor and non-motor features are common in patients with ET, and further studies are needed to clarify ET phenotypes and to provide insights into possible subtypes. So this is our first attempt to classify ET into subtypes. This is a paper that was just submitted into Journal of Neurological Sciences, where we suggested there may be different subtypes in addition to pure or isolated ET, ET Parkinsonism, ET dystonia, ET ataxia, a number of other ET plus conditions that may represent different subtypes that perhaps have underlying unique etiologies. This is analogous to Parkinson's disease subtypes. Here we suggested at least two dominant subtypes, tremor dominant PD and PIGD, or partial instability, gait difficulty in form of PD. And in the tremor dominant PD, one often finds coexistence with essential tremor. Finally, I wanted to draw your attention to this paper that was just published that I think is a really beautiful review of the different subtypes, including subtypes in a prodromal phase of the disease. So, for example, the authors indicate that there may be a tremor dominant subtype that we referred to before, and then the PIGD subtype. The tremor dominant form of Parkinson's disease tends to progress at a slow rate compared to the PIGD subtype, which progresses more rapidly. And it is the tremor dominant form of Parkinson's disease that may often overlap with essential tremor. So how are Parkinson's disease and essential tremor related? We still don't have a clear understanding, but there are several lines of evidence from clinical, epidemiological, imaging, genetic, and pathological studies supporting a link between essential tremor and Parkinson's disease. We suggest that there is a subset of ET patients who appear to be at a high risk for developing PD. Many patients have PD with antecedent ET, but ET may follow onset of PD, so that's something that we should always keep in mind. PD patients tend to have a slower progression, more favorable prognosis compared to other PD patients, particularly compared to the PIGD PD patients. So we conclude that better understanding of idiopathogenesis of ET and PD and their subtypes will lead to better insights into the relationships between these two common but not well-defined movement disorders. So I hope you'll come to visit us here in Houston. This is the Texas Medical Center, the world's largest medical center, and this is the McNair campus where our clinics and laboratories are. So thank you for your attention. And again, I want to thank the organizing committee for inviting me to give this Mel Yahr lecture. Thank you.